We've chosen to do topic 1, which is about obesity and how it can have multiple negative effects on the body. Meet Mark. Mark is a 52-year-old male who has been working in a manufacturing factory since his early 20s. His height is 165 centimeters, weighs 90 kilos, and has a BMI of 33.1, which is considered obese. As his daughter is getting married, he and his wife Susan have been increasing their working hours over the past couple of months to help pay for this special occasion. Mark has found that due to the very long hours, he has very limited time to eat and finds himself eating fast food 3 to 4 times a week. He is a non-smoker, takes no regular medications, has had no other serious illnesses, however, is at high risk for developing type 2 diabetes. Mark had appendicitis at the age of 6 and as a result removed his appendix. He also suffered from tonsillitis as a child and also got a tonsillectomy. When he was younger, he played soccer at a high level and suffered ankle injuries on the same foot that is now giving him problems. When he was 18, Mark suffered an ankle fracture, which took up to 6 months to heal as he did not follow rehab protocol. He has had one podiatric case in the past where he presented himself to a local podiatrist and was prescribed orthotics to help correct his flat feet. He has admitted that he forgets to wear them sometimes and does not attend regular ongoing checkups or treatment. Mark has increased his work hours over the past couple of months. As a result of this, he has experienced intermittent bouts of right foot pain, mostly at the back of his foot at the heel. However, now it hurts constantly. Mark has also noticed swelling and inflammation at the heel. He is experiencing post-static dyskinesia, whereby the pain is mostly present in the morning after waking up and late at night when he finally gets to rest on the couch. Sitting with the foot elevated relieves the pain. However, when he has been on his feet all day, it does take a while for the pain to reduce. Mark has recently purchased new steel-capped work boots that have not yet been worn in, and so he believes that this could be contributing to his foot pain. Mark has no previous history of similar symptoms. The differential diagnosis made by the podiatrist include plantar fasciitis, Achilles tendinopathy, and retrocalcaneal bursitis. Achilles tendinopathy was determined due to repetitive strain, stiffness in the morning, and calf tightness. Retrocalcaneal bursitis was considered due to the redness and swelling, the local pain, the heat at the back of the heel, and it was a bit tender on touch with the inflammation. However, plantar fasciitis was the working diagnosis due to the pain in the morning, the heel pain, the gradual onset, new footwear, increased working hours with the overactivity stimulation, his weight, and also his lifestyle contributions. The plantar fascia or plantar aponeurosis is located on the sole of the foot and is composed of densely compacted collagen fibers. Its medial and lateral borders overlie the intrinsic muscles of the hallux and the fifth digit respectively, while its dense central part overlies the long and short flexors of the digits. This structure originates from the medial process of the calcaneal tuberosity on its inferior aspect, proximal to flexor digitorum brevis. Posteriorly, the fascia is narrow, and when traced distally, it becomes both broader and thinner. The plantar fascia divides into 5 bands, one for each toe, just proximal to the level of the metatarsal heads. The lateral part of the plantar aponeurosis covers abductor digiti minimi and is thin distally whilst thick proximally. The medial part of the plantar fascia, which covers abductor hallucis, is thin. At the ball of the foot and the metatarsophalangeal joints, the superficial layers of these fibers insert into the dermis. In contrast, the deep layers of each digit becomes septa, and that separates the digital flexor tendons from the lumbricals and the digital vessels and nerves. This dense tissue tissue structure assists in supporting the long arch of the foot by acting similar to the string on a bow. There are multiple causes of plantar fasciitis, some of which include age, trauma, obesity, flat feet, high arches, prolonged weight bearing, and fat pad atrophy. In relation to Mark, there are various factors that could explain why he is experiencing plantar fasciitis. Firstly, as Mark is aging, the fat pad of his heel may progressively become thinner, which can lead to inadequate padding and chronic pain in this region. Secondly, Mark's obesity and prolonged weight bearing from working long hours can place a severe amount of strain on his plantar fascia and therefore may be a causative factor. Butterworth conducted a study which aimed to discover the correlation between obesity and foot pain. Table 1 shows that 21 out of 31 participants who were classified as obese were victims of foot pain, equaling up to 68%, whereas 13 out of 35 participants who were classified as not obese complained of foot pain, totaling to a contrasting 35%. The same study then searched for the differences in plantar foot loading between obese and not obese participants. Table 3 indicates that those in the obese category contact area in the midfoot of 30.7 centimeters squared compared to 21.7 centimeters squared for non-obese participants. In continuation, it was found that the maximum force of obese participants was 40.4 kilograms and 20.8 kilograms in the heel and midfoot respectively, which contrasts in the same anatomical positions for these non-obese participants who recorded an average of 32.6 kilograms and 8.9 kilograms of force on the heel and midfoot. The combination of these two measurements lead to a peak pressure of 2.2 and 1.3 kilograms per centimeter squared in the heel and midfoot for obese participants, which is considered more than those of the non-obese participants, who recorded 1.8 and 0.7 kilograms per centimeter squared of pressure in the heel and midfoot. Information that can be concluded from these results is that individuals who are classified as obese have a larger amount of pressure on the foot and ankle during walking and running, which places more stress on the anatomical features of the foot and ankle, thus making them more vulnerable to developing plantar fasciitis. As depicted in the systematic review by Butterworth, Landorf, and Smith, plantar fasciitis can be seen to have a strong correlation in obese individuals. While this study further developed an understanding into all the musculoskeletal foot disorders associated with obesity, the evidence over the 25 included articles show a strong association between an increased body mass index and developing the symptoms of chronic plantar heel pain. The articles used within the study included case control, cross-sectional, and prospective cohort designs, with letters to the editor, opinion pieces, and its editorials being excluded to help reduce bias. Within the review on chronic plantar heel pain, 10 studies using non-athletic individuals were used, most of which contained a large number of participants. It was concluded that 9 of these determined that a large BMI resulted in individuals experiencing plantar fasciitis, with the one article disagreeing with these trends included a very small number of participants within the study. Overall, the primary outcome of heel pain present within the individuals with a large BMI included the diagnosis of plantar fasciitis. While obesity continues to increase in many developed countries around the world, it's important that podiatrists use the most advanced treatments in either surgical or non-surgical to help with the management of plantar fasciitis. As illustrated by Lewis, Wright, and McCarthy, the use of a variety of non-surgical modalities can improve symptoms in the short term, with those suffering acute plantar fasciitis. These include orthotics, night splints, manipulation chiropractic, physical therapy, corticosteroid injections, and NSAIDs. In more advanced cases, where a heel spur has occurred, other surgical procedures may be considered to reduce the inflammation of the plantar fascia. Thank you for listening.